My name is Samantha Butts. I am the Division Chief of Reproductive Endocrinology and Infertility here at Penn State Hershey Medical Center. We are going to have a dynamic panel discussion from the perspective of some of the most incredible experts in women's health, obstetrics and gynecology, reproductive endocrinology, and management of fibroids to talk to you about this condition. And I'm probably preaching to the converted in this room and people on this panel, but I think there's an opportunity for all of us to learn when I say that fibroids are a common and prevalent condition. It always surprises people when I say to them that the lifetime likelihood of a woman developing fibroids is somewhere in the range of 70 to 80%. And people look at me and they don't necessarily believe that's the case. And the reason for that is that fibroids can look very different depending on a variety of things. There are patients who have asymptomatic fibroids. There are patients who have a lot of problems and debilitating symptoms with their fibroids. And we're here to talk about all of that, but really the way that fibroids show up in patients attempting to become pregnant and how it can affect their fertility goals. We wanted to make this a conversation that was not just about the opinions of the people who care for patients, although we know that's incredibly important, but we really wanted to involve patient perspective. And so we're going to start this off with a wonderful ambassador and beloved patient of ours in our practices here named Deshona Fox, who's going to talk about her experience as a patient with fibroids who face fertility. I'm going to go down the line of our panelists. After Deshona, we'll have Dr. Stephanie Estes, who's going to talk about the diagnosis of fibroids and their effect on fertility and early pregnancy. Dr. Estes is a reproductive endocrinologist and the head of our reproductive surgical program here at Penn State. Following that is Dr. Mayowa Dayo, who is going to talk to us about medical management of fibroids in women desiring pregnancy. Dr. Dayo comes to us from the University of California, San Diego, and spoiler alert, she's going to be joining the Division of Reproductive Endocrinology and Infertility in less than 6 months, and we cannot wait to have her. And this is our opportunity to really introduce her to our community here at Penn State. Following her is Dr. Annalise Williams, who's going to discuss the surgical management of fibroids in women desiring pregnancy. Dr. Williams is an OBGYN and a minimally invasive gynecologic surgeon. And last but certainly not least is Dr. Tonya Wright, who is the chief of our division of academic OBGYN. And she's going to talk about pregnancies in women with fibroids and after fibroid treatments. Our panelists have a lot of experience, but they're going to sort of have concise and comprehensive remarks. We want this to be an opportunity for patients here in the audience and patients online to have their questions addressed. Unfortunately, I'm not going to be able to get to everyone's questions, but we do want to have an opportunity to keep this dialogue and conversation going. I'll ask Dr. Estes to maybe talk a little bit about some of our future plans in the division to increase access to excellent fibroid care in our population. So with that, I'm going to ask Deshona to come up to the podium here and thank her so much for sharing her story and experience with us.
Hi, everyone. So my infertility journey started in 2019 before I realized I would have an infertility journey. I think up till that point, I had just kind of assumed that the natural order of things is you date, you get married, you have kids. Like that was just how things worked. And so I had finally decided to go see a doctor about what I thought was abnormal pain that I was having during my periods. And up till that point, what I had been told was, it's just period pain and you probably have a low pain tolerance. And so I said, okay, whatever, I'll just deal with it. So finally, I was like, this is a little weird. I'm taking off, monthly sick days, and that's probably not the way things are supposed to be going. So I decided to go in. I saw a doctor about all of this problems that I was having, got an ultrasound, and then got a call from Dr. Wright to come in and see her. And so we had a conversation about then what I would discover is PCOS and uterine polyps, possible endometriosis. So there are lots of issues that would need to end up in a surgery to remove those uterine polyps, which is where I then discovered my fibroid, because prior to that, it was just sort of hiding. It was a little shy, didn't want to be seen. And so during that surgery, they discovered the fibroid, and that would essentially start what would become my very long journey to having my beautiful daughter that I now have, who's 5 months. So we discovered this fibroid. I went in, I had a conversation with Dr. Wright. She recommended that I go see REI, and that was probably the first time that it actually hit me that I would have difficulty becoming pregnant. I don't think before that, I mean, I had known about PCOS, I had known about, fibroids. I don't think I had ever put it together that would affect what I would consider my perfect journey to marriage and family. And so that was kind of a gut punch at that point. I was like, okay, well, I'll go and do this consult. I'll see what will happen. At the time, I was like, oh, I don't really know how this is going to go. I probably freaked out a little bit. Dr. Estes was actually the person that I first consulted. This is a very full circle moment for me. So Dr. Estes was the person that I consulted with, and that was the best decision that I could have probably made at the time, because I would be making a lot of decisions that would affect my future. And if I hadn't had that conversation, I don't think I would have been as well informed to be able to make some of the hard choices that I would make. The biggest one being that I think for most women, you would think that when you become pregnant, you're going to have that natural pregnancy, the journey to a natural childbirth, and all of that would sort of be taken out of my future after that. So I would then find out after having my myomectomy that I would then have to have a C-section. And so that was another thing that it was like, oh, okay. But it's fine. I was like, plenty of people have C-sections. That's fine. And so there are a lot of points throughout this process that I would consult with 3 of the doctors on this panel here, just to answer some questions that I have. And I don't think, if I didn't have that, I don't know that my process would have gone the way that it did. It was still difficult. After my fibroid removal, I got married, then decided to start having children, and that would be where my IVF journey started. And that was really difficult. We had 2 failed tries, 1 miscarriage, and then finally our successful try. And during that entire process, all I kept thinking is, there is nothing in me that would have known that this is the journey that I would have gone through. And so that was really difficult. I could have probably used a panel like this prior to that so that I would have some understanding of what I was going through, because everything felt new and fresh and really difficult every time we would hit some sort of barrier to what we thought would be the perfect story for us. And so I think panels like this are probably super important, and I hope everyone takes that really seriously, because I know as a patient myself, that would have been really helpful going through this. So trying not to get super emotional here with my baby. So yeah, that's my journey.
Thank you so much for that. It's a hard thing to talk about. And I really do appreciate everybody's attendance here and everyone's attendance online, because it is often very difficult to talk about OBGYN things. And so I think today we want to kind of learn together, and I really welcome everyone's input. And then we can also do those questions that we were talking about. And we are trying to develop easier access to discuss just these things, such as having a fibroid infertility clinic, especially for patients with just those issues. So I know that there are lots of questions every time my patients come in to talk about fibroids. So let's take a look at a couple of those things and go through fibroids and how their effect on infertility. So some of us here today are reproductive endocrinology and infertility subspecialists. And so I just wanted to note that that's a role, we think of as a fertility specialist. But what we're really looking at when patients come into us with fibroids is how do we look at that person and that couple as a whole picture? And then allowing the anatomy and some of the other things that we think about to provide us with answers on how to get to the goals that you want to get to. And that's why, as fertility specialists, we think about uterine fibroids, because uterine fibroids can certainly affect the fertility journey. So a lot of people, they say, Dr. Estes, what in the world are uterine fibroids? And it's such a challenging question, like even for medical providers, even for our students. So fibroids are a monoclonal growth. That means like one cell type proliferates over and over again. It often forms like a baseball type structure that's very firm and white. They can look different, but that's one example. And they can be located in very many different positions. So in this classic image, you can see those white ball-like structures. And let's see if this pointer is here. Oh. You can see that there are different ways that we see the uterine fibroids. And so there's some inside the cavity, there's some off the top of the uterus in different locations. So uterine fibroids can cause different symptoms. So you can see, depending on where the location is, where the size is, how many there are. And so it's also challenging, to compare online with other people what they're saying about fibroids and maybe their assessment or their treatment, because there can be so many different types of them. And so the location, size, and number are the things that need to be investigated in terms of talking about uterine fibroids. Because we have the symptoms, we have pressure, we have pain, we have bleeding, maybe heavy bleeding, maybe irregular bleeding. Or sometimes, you don't have any symptoms at all, and then that's where we're seeing patients for infertility, and you're identifying that that might be a potential cause of a problem. So how many persons do have uterine fibroids? Well, the incidence increases with age, and about 3/4 of hysterectomy specimens have fibroids. So we know that it is something that is very common, as Dr. Butts already mentioned. Up to 25% of women with reproductive age concerns have uterine fibroids. I mean, think about that. 1 in every 4 persons has uterine fibroids. And especially, we want to keep in mind certain populations that are increased risk. So Black women and Asian women compared to white women. And also that Black women have much larger fibroid size and more fibroids. And then you can see the implications of that. So the next question that we often get asked is, where are my fibroids? And that is a very difficult question to also answer because they can be in very many different locations. So you can see the numbers on this picture. And so they're categorized in different ways, whether more towards the inside of the uterus, those 0, 1, and 2. You have the ones in the muscle of the uterus. So those numbers 2, 3, 4, 5, or fibroids that are more towards the outside of the uterus. So again, it's important to think about, and I think this is where we can help you as providers understand more about fibroids, because what we do and how we address this depends on the location. And some of them impact fertility or pregnancy in perhaps a different way, depending on if they're in the cavity of the uterus, outside of the uterus, and again, the size and number. So how do we diagnose uterine fibroids? And if there was one thing I would say to take away from my part of this, this is the key part. we want to look at ultrasound. So if there are concerns, if there are questions about uterine fibroids, let's just not say the patient's symptoms are either made up or less than what they are. Let's take them seriously and let's do something to find out about what we can do for uterine fibroids. So here is a picture. And again, if I step away, it's probably going to be hard to see. But here we can see a uterus, the top picture, and there's a little ball-like structure. And so let's see if we can get that. Okay, sorry, you guys can't see the red dot, correct? And probably not online, so I apologize. Online people, let's see if we can see this little fibroid here. There's a little grayer circle that's at the top of that uterus above the 3 white lines. So the 3 white lines are the endometrial cavity where the pregnancy would be. And then you can see a tiny fibroid. So that fibroid doesn't have any clinical implications. That's not something that would need to be removed or treated. But the one on the bottom corner, you can see where the black fluid surrounds that ball-like structure in the center of the uterus. That's a structure that could impact fertility or pregnancy. And then sometimes we need to do a little bit more testing. So MRI is also a great test. So if you have any providers who are talking to you about MRI, spot on. That's something that is really, really helpful to identify the size, location, and number of fibroids, intentional redundancy, and saying these things, because those are the key factors that we look for. And the white area you can see is pointing to a fibroid that, again, is larger than typical and in the cavity. And then the other MRI to the side of that is a little bit tougher to read, and that's intentional because there's just multiple fibroids there. You can't actually see where one starts and the next begins or ends. And multiple fibroids, again, are treated in a different way than maybe a singular fibroid. So how do we address these uterine fibroids? And the second take-home point from this part would be just looking again at the whole picture. So we want to have that imaging. Ultrasound is key as a starting point. The second thing is we think about the other parts of and components of fertility testing. So tubal evaluation is very important, as well as a semen analysis or looking at donor sperm to have the options of what we're going to do for management. So uterine fibroids play into this bigger picture of things, and that's how we as reproductive endocrinologists and fertility specialists can help. So, warning, I'm going to show some surgical pictures. So just to let you know, I think I find images just to really say a lot about what you can see and what you think about for fibroids. So we're going to get to those next. And what they look like can be very different, but their impact can be the same. So they can affect the symptoms, the bleeding, the pain, the pressure, infertility. They can affect pregnancy outcomes. So whether it's pregnancy loss or the growth of the pregnancy, preterm labor, preterm delivery, those things all can be affected. And then we can impact those outcomes by addressing uterine fibroids. So let's go through a couple of pictures here. And so we have the MRI picture. And if you look centrally, let's try this one more time. Okay. We look centrally, we have this uterine fibroid, and then you see that white kind of fluffy stuff on the top picture. That's actually what the fibroid looks like when we look in through the vagina, the cervix, and into the uterus. So you can see that white tissue. And the above picture is before that area or that fibroid is removed, and the bottom picture is after it. So again, as a reproductive surgeon, I am trying to help my patients address their uterine fibroids in the best way for fertility. And a lot of times the question is, well, what ways can we do that? And often we're talking about surgery just because it's a great way, and we'll get into other things with our other panelists. But just to let you know, this is what a fibroid looks like in the cavity. And you can imagine then that the impact of a miscarriage, if an embryo lands on that, which is not a normal uterus, can cause a miscarriage, or its placement of the pregnancy can affect outcomes. Here's another picture of the next uterine fibroid. This fibroid is more off the top of the uterus, And so you can see that that fibroid is to the side and it's kind of pushing the uterus. So again, another way that fibroids can impact our outcomes. Compression can cause pain and potentially be there as a solid structure that is in the pelvis, causing those symptoms. So on the laparoscopy picture, you will be able to see that towards my side over here, there's that multilobulated structure. That's what the fibroid looks like. And then the intestine is to the side of that with those yellow pieces. So another way that fibroids can impact and present themselves. Here's another photo of a fibroid on the MRI, and then you can see the little grasper holding on to that white structure. So think about implantation, think about the blood flow changes that might come to the uterus going towards that fibroid as opposed to perhaps a pregnancy. These are the ways that fibroids can be associated with infertility. And also, as persons get older, we know that the fibroids are more common, and so therefore both age and the fibroids can impact the things that we need to accomplish. And so again, that's why we put all these things together for a treatment plan. And then this is the last slide of the pictures, which I hope that you enjoyed. The fibroid top corner, and then the uterus repaired. So, all those suture lines in there, the uterus heals great. It works extremely well after fibroid surgery. But again, I think it's just helpful to see what fibroids look like. You never get to actually have that view with an interpretation. So I hope that those pictures were helpful. So if we know that someone has fibroids, then we can really assess them. And we can also discuss all of the treatment options that are available. So I'd like to turn it over to Dr. Dayo, who's going to speak about the medical management treatment options. And thank you for allowing me to share these with you today.
Perfect. Thank you everyone for being here and for having me as well. And Dr. Estes for introducing this. So I think a lot of times, a lot of our patients ask like, did I do something wrong? Can we avoid surgery? And so that's going to be my piece, is to talk about, are there ways that we can manage fibroids, especially for our population who are trying to get pregnant. We would really love to avoid surgery if we can, but as we've just heard, there's no one size fits all. Fibroids come in different shapes, in different locations. And so if you were to take 5 women and put them together, they might have different managements for their fibroid. Ultimately, there are some medical managements prior to getting pregnant. The big takeaway is there's no medication that we can give you while you are pregnant that is going to improve your fibroids. So anything I talk about would be done outside of pregnancy, so before you get pregnant, and then potentially if you get pregnant successfully and the fibroids grow, after you're pregnant. So that's kind of the 2 phases that we'll be looking at. And to give you kind of a nice bird's eye view, there are multiple options for treatment, and I've highlighted the blue parts, which is what I'll be talking about. I'll be starting with lifestyle and nutrition, which is what our patients can do at home. The biggest takeaway from lifestyle and nutrition is that there is no one size fits all for this also. And there's no one pill or like food you're going to eat that's going to get rid of fibroids. Generally, having a healthy diet, so your perfect portions of fruits and vegetables, potentially decreasing dairy and potentially decreasing red meats might have some impact, but there is no one study that has looked at people who ate less dairy, ate less red meat, and then looked at people who ate tons and tons of red meat to say that one is worse. But when we look at multiple studies that have been done on small populations, there is potentially some positives in terms of eliminating some things from your diet. And then there are other things that have been put on the market or kind of talked about in different forums that have no clear evidence. And then I will also touch on the medications that we have that we know do work in terms of shrinking some fibroids or getting us to a point where we might have a minimally invasive surgery versus a bigger surgery. And so we'll kind of go over that too. So for lifestyle and nutrition, when we think about what could actually help, for vitamins, there's been a lot of studies on vitamin D. I would say vitamin D is probably the biggest one that we have enough data on. And when we're thinking about what works for a large population of people and not just, let's say, people here at Penn State, we want to know, does it work for someone at Penn State? Does it work for someone in New York as well as someone in California? We're really looking for studies that have a very diverse population, is rigorously done, so that then we can say whoever's coming into the room to talk to us in clinic, I have really good evidence to say that this is going to make a difference. And of all the things listed on here, the only one that has really sufficient evidence is vitamin D. And the conclusion that was found for vitamin D is that women who tend to have fibroids and have tons and tons of fibroids tend to have lower vitamin D. That does not tell us if it's the vitamin D that was low first, or if it is the fibroids that came and with the vitamin, you just don't know which one came first. So ultimately, having normal stores of vitamin D for all women is a very good thing to have. What we are unable to say is, if you supplement vitamin D in someone who has low vitamin D, does that improve or decrease the size of your fibroids? That has not been shown. So for vitamin D that we know, keep your vitamin D levels up, which is just sunlight. Most people can get that from sunlight. And then if you have lower stores, certainly getting your labs checked with your doctor. And if it's very low, then they can also supplement that. So that's a very easy fix if your vitamin D is low, whether or not you have fibroids. The other vitamins that have been looked at are vitamin C, vitamin A, and B3, and there's unfortunately just not good enough data to show. Vitamin A levels that are low, again, are correlated with having fibroids, but there's nothing on supplementation, and there is very little on vitamin B3 as well. Green tea is another one that was very hot for many years, and they've looked at doses from 290 milligrams. To put that in perspective, a cup of coffee from Starbucks has about 150 milligrams of caffeine. And then if you were to take the average green tea just off a tea bag, it's about 75 milligrams. So they're giving very high doses of the main extract of green tea, anywhere from about 280, 290 milligrams, all the way to 800 milligrams. And people felt great. They felt really good. You feel like your metabolism is moving pretty well, but there is no reduction in the size of fibroids. So unfortunately, I think that green tea has very great and fantastic antioxidant benefits for health, but we have not been able to show that it can decrease the size of fibroids, even at very high doses that the average person would not be able to tolerate. And then fruits and vegetables, certainly good, but there's no one fruit or one vegetable. In some populations, for example, in Chinese Americans, they found that if you ate a lot of bok choy, that would be great. Not everyone eats bok choy. If you ate carrots in some populations, that was great. But overall, the general consensus was fruits and vegetables have high amounts of antioxidant. We think that the growth of fibroids might be linked to some form of not having enough antioxidants in your system. And so just having a very balanced diet potentially could be helpful. High levels of dairy, specifically, it's the dairy that potentially might have exposure to estrogens and progesterones and other things if they're not like grass-fed, if you want to think about that. So in countries where their dairy do not get supplemented at all, they find that there's lower rates of fibroids. It's also very difficult to say that that is the main thing, because a lot of those populations are not Asian and Black, where we see higher numbers. So if there are already very low numbers already in that population, can we really say it was the no estrogen, progesterone, or hormones in the dairy? Or is it just that that population is not as prone? But generally, I think that the consensus across the board is that dairy is very normal to have, but if you were to decrease your dairy, potentially that might have some benefits for you. And lastly, environmental exposures, specifically endocrine disruptors. We find that in plastics, the bottled waters we're drinking. It's just everywhere, and it's very difficult to avoid. And those also can impact the hormone levels. Again, there's no way to completely avoid all of these things, but just being careful about your plastic use, your exposure to toxins, whether it's from insecticides or just the things that you're buying and putting on your skin. Generally, if you're decreasing that as well, that impacts not just fibroids, but a lot of other diseases that we can find. And now I'm going to move on to our next one, hormonal versus non-hormonal therapies. And this is where we're thinking about our medication. So ultimately, based on all those symptoms that Dr. Estes mentioned, you're going to have bleeding, you might have pain. There's going to be medications that are very, very helpful to decrease the amount of bleeding you have, depending on where the fibroid is. Generally, if the fibroid is right dab in the middle of the cavity, there's not too much we can do. We can maybe decrease the bleeding a little bit, but eventually that fibroid physically has to be removed for the bleeding to stop, because it is just a constant source of worsening bleeding. So if your fibroids are in other places and you're maybe having discomfort with sexual intercourse, or maybe you're having a little bit of a heavier bleeding, there are medications such as tranexamic acid that you can take around your cycles just for like the week or so when you're having your period, that can decrease the amount of bleeding you're having. It does not shrink the size of the fibroid, and it does not make it go away. The other would be over-the-counter non-steroidal anti-inflammatory drugs, NSAIDs, that you can always get over the counter to again help with bleeding and pain related to fibroids. The bigger, stronger medications that I have on here, specifically the very first one, which we just use an acronym GnRH, either agonist or antagonist. These are big medications that really target the hormones that are potentially feeding the fibroids and kind of help them to shrink. We cannot use this during pregnancy because you need all those hormones around. So these are medications that, one, we can use for a short period of time because it does make you feel like you're in menopause, and that does not feel great. So there's limitations for how long we can use them. And if you have really large fibroids, as our surgical panel will talk about, sometimes it's a very good idea to take these medications to shrink them so that then we can have a better surgical technique to take such fibroids out. There are some, so most of these, they used to be just injections that we had available. There's now GnRH antagonists that are in pill form that you can take for up to 2 years that have actually been looked at, and they've shrunk the size of the fibroid in populations of women that have used it. Again, the side effects do persist in terms of menopausal symptoms, and that is the primary reason why women get off of them. Having an IUD can be helpful for bleeding if you do not have a fibroid inside the cavity. And that can just kind of help regulate things while you wait for your next step. And then I had mentioned also some form of oral contraceptive for, again, heavy bleeding, or progesterone for heavy bleeding. None of these options, unfortunately, can decrease the size of the fibroid. Sorry, can eliminate the fibroid completely, except for the top one that can decrease the size of the fibroid. And I will pass on the torch to talk about surgical management next. Thank you so much.
Hey, hello, everyone. My name is Annalise, like Dr. Butts mentioned on her introduction. I am currently the first-year fellow in minimally invasive gynecologic surgery. For those who aren't familiar with this field, we focus on benign gynecologic conditions for patients who may or may not desire future fertility, more specifically conditions like endometriosis, fibroids, chronic pelvic pain, and we work hand in hand very frequently with our REI colleagues. And if you have any pregnancy-related questions, we will refer you back to them. But I get very excited about surgical management of conditions like fibroids, which I will be discussing. Like we previously talked about, the big question is, do I have to remove my fibroids? Especially in the context of pregnancy, that's when we really look at the location of the fibroid within the cavity of the uterus. We already had a similar picture in terms of where exactly is the fibroid located. Most importantly, if it's 0, 1, or 2, most likely you would have to get that removed prior to getting pregnant to have a successful pregnancy. Other things that are important, though, is that if you have a fibroid that might be a little further out, if you have bulk symptoms is what we call when you have a lot of abdominal pain or like bladder urgency, we might also suggest getting it removed just so that you can have symptomatic improvement. Whenever we do procedures, the most important thing that we talk to patients about are their symptoms. And if you have bleeding, I will say it's very important for us to check those labs. And if you are chronically anemic, like we mentioned, we very frequently have to prescribe medications like tranexamic acid because being anemic has been shown to have worse outcomes postoperatively before we do any sort of procedure. I have procedures kind of listing from the more minimally invasive to more invasive. I just have one slide on uterine fibroid ablations because I know this has gotten very popular in the community and this is something that's searched very frequently online. This is not a procedure that we do at Penn State currently, but I have seen it done at different institutions. The procedure can be done vaginally or laparoscopically. Small incision, if you do it abdominally, can be made to make space for the ablation device. A special needle is inserted into the fibroid, and there's like a array of needles that spread. In basic terms, essentially you microwave the fibroid so that afterwards the hopeful plan is that the fibroids will shrink postoperatively. The fibroids are not actually removed for this procedure. The pros are if you do it vaginally, there's no incision in the abdomen. And if you do it in the abdomen, there's no incision on the uterus. So theoretically, there's a faster recovery period for, getting back to activity. The cons are because this is a newer procedure, this is actually not advised if your plan is really pregnancy as being the big thing on your list. It's currently under studies as to what the effects are on pregnancy. We just don't really know what the success rates are afterwards. So I would say if fertility is your goal, I would not get an ablation. Moving forward with our other procedure, the most common one we do is called a myomectomy, and that's just the fancy term for removal of the fibroid surgically. In terms of the more minimally invasive approach to myomectomy, a hysteroscopy is when we do it from a vaginal approach, which we already discussed briefly. With that, there are no abdominal incisions that are made, and like I said, there's going to be a shorter recovery time with that. The cons is that the fibroids must be within the uterine cavity for us to access it from a vaginal approach. You can see in the picture that we insert a special camera into the cervix, into the uterus, so you only see the lining of the uterus. If they're outside of that lining, you're not going to be able to access it hysteroscopically. And if they are too large, there are some cases for which patients have had to come back to surgery multiple times to get the fibroid completely resected because they cannot do it in one go. Unfortunately, whenever we do this procedure, we have to fill the uterus with fluid. And once you hit a certain maximum deficit is what we call it. When you've hit your maximum fluid, you have to stop the procedure. The next sort of level of invasiveness is the laparoscopic myomectomy. Laparoscopy, for those who are unfamiliar, are when we make small incisions in the abdomen. They're about fingertip size, 1 centimeter or so, to be able to access, putting our camera in as well as our special instruments. We then can use these incisions to put special instruments in, cut the uterus open, and be able to remove the fibroids that way. If we do this procedure laparoscopically, like I already mentioned, the pros would be that we can keep our incisions small, which usually leads to better recovery process for patients. Most patients who have laparoscopic myomectomies are able to go home the same day. The overall recovery process is about 4 to 6 weeks. The cons are because you're not actually feeling the uterus for this procedure, the fibroids that might be deep within the uterine cavity or within the wall of the uterus, we're unable to access usually doing this laparoscopically, so they're less likely to be removed. This is a really great procedure for patients who have one predominant fibroid, which we can easily just incise, take out, and remove from the abdomen. A lot of patients who undergo this procedure, usually when I talk to them preoperatively, ask, how are you going to remove my fibroid that's 10 centimeters from a 1 centimeter incision? Usually we place a bag in the abdomen, we place the specimen within the bag, we bring it to the abdomen, and we do a special process called morcellation, where you bring the fibroid up and you cut it into smaller pieces so you can actually remove it from the abdomen without excising it, make a bigger incision. It's a pretty long staking process, so usually we tell patients that this might be a 4 to 6 hour procedure depending on how many fibroids they have. The most invasive myomectomy procedure is called an open myomectomy, and that's when we make a C-section-like incision on the abdomen that's horizontal. And it depends on really the fibroid size and how big our incisions are. The pros of this is that we can completely remove every single essentially fibroid within the uterus because we can feel the uterus along the procedure. The cons are because it is a larger incision, there's a higher chance of infection, scar tissue, and typically patients do have a longer recovery process due to this. More recently, we've been doing a lot of studies on a mini open myomectomy or open laparotomy, and that's when we keep the incisions to about 6 to 8 centimeters. And it's been shown that it's pretty much almost as effective and as well healed for patients compared to laparoscopic myomectomies. So that's something to consider in terms of incision size if this is a surgery that you're interested in. In terms of the recovery process from these surgeries, like I mentioned, there's a kind of a wide variety of how invasive we go, depending if it's hysteroscopic, laparoscopic, or open. Typically, with the hysteroscopic myomectomies, we tell patients to definitely just recover for at least 24 hours. Depending on how large the fibroid was, we might say a couple days to a week, but usually the median time is about a couple days. In terms of laparoscopic and open myomectomies, the recovery process is a bit longer. It's 4 to 6 weeks in terms of downtime, especially because you really want to give the uterus a good amount of time to heal the scar. Patients after these procedures, if it's hysteroscopic, you usually have a pretty short period of time where you can conceive. If it's laparoscopic versus an open myomectomy, however, and if the fibroid is significantly within the wall of the uterus, usually we advise waiting 3 to 6 months to conceive so that there's enough time for the uterus to heal. With that, depending on the location of the fibroids, we will counsel patients, whether they may or may not be a candidate for a vaginal delivery. And that it does vary in terms of how significant the fibroid has gone into the uterus to heal. The reason that we suggest doing a C-section for specific myomectomies is because if a patient comes in full term and they're contracting against a scar doesn't contract the same way the rest of muscular tissue does. The worst outcome that can happen is called a uterine rupture, and that's when the scar actually opens up, which is a very catastrophic event that obviously we would like to avoid for our patients. So that's why we will counsel them on doing a C-section at the time of their pregnancy. And that's all I have.
Thank you so much. Perfect segue to my section, which is on pregnancy in women with fibroids. I am Tonya Wright, the division chief for the academic specialist group, and do bread and butter OB-GYN, take care of laboring patients. And I actually had the distinct honor of bringing our beautiful baby into this world. I've been following with Deshona since 2019. So talk about a full circle moment when I was able to be there on her delivery date to do the C-section, which was uncomplicated and was a very beautiful experience for everybody involved. So my goals for today are to review pregnancy considerations with women who have fibroids, but also for patients that have had fibroid treatment already. So you've heard most of this already, but most pregnant patients actually have no complications even in the setting of fibroids and having undergone prior surgery. So that's the good news. The most common problem is actually pain in pregnancy, and we'll talk a little bit about that. Fibroids tend to grow in pregnancy. It's getting so much blood flow to the uterus for the pregnancy to develop, and the fibroids tend to really capitalize on this newfound rich blood supply to the uterine cavity. And so they can grow. And if they grow, they tend to be later in the first trimester and in the early second trimester. Again, you've heard the recurring theme. What the impact will be on your pregnancy is directly related to the number of fibroids, the size of the fibroids, and the location. Again, not a one-size-fits-all model. And so really having detailed discussions with your doctors about where your fibroids located, how could they specifically, your fibroids impact your pregnancy depending on where they're located. I like to describe fibroids to patients based on fruit sizes. I think it really helps them to conceptualize in their mind what we're dealing with. Just today, I had a patient who had an ultrasound who was really panicked about the fibroids that were documented on her report. They were all about 1 centimeter each. And I had to say, that's about the size of a blueberry, and they're in the muscle. These will not have an impact on your pregnancy. And that was really a great way for her to have that aha moment that based on the size, this is going to be okay. We've all taken care of pregnant patients that have any number of different size fibroids in different locations, and so the impact would be different. That being said, pain tends to happen most frequently in the patients that have larger fibroids or in the fibroids that tend to grow in that first trimester. And the reason for that is because as the fibroids are growing, they can actually outgrow the blood supply that they're getting, and they can necrose or die off in the middle of that fibroid. And that dying off process is very, very painful. Not harmful, but painful. And sometimes it's so painful that we have to actually hospitalize patients early on in pregnancy to kind of manage their pain. Not that it's necessarily harmful to the pregnancy, but for their overall quality of life. Um, we try to be very conservative with how we manage patients. You may know in the non-pregnant state, if you could take some anti-inflammatories, NSAIDs, ibuprofen, it probably would have a good control on the pain, but those medications are not necessarily allowed in early pregnancy. And so we're very limited to what we can offer you, which is why it's such a struggle sometimes to get the pain under control. We generally recommend for mild and moderate pain that it's safe to take acetaminophen pretty liberally as directed. For more severe pain or pain that's refractory, sometimes we'll bring patients in and do short courses of opioid management, so narcotics. These are really in extreme cases. And in instances where the pain is even more severe and patients are admitted under the gestational week of 32 weeks, we can offer something called indomethacin or other specific anti-inflammatories that are safe at that gestational age. We try to avoid those in patients that are beyond 32 weeks pregnant. Other complications, and I just ran down a list here, probably the most concerning would be the risk of preterm birth. There's a documented 1.5 to 2 times increased risk. And the reason for that is very simple. It's almost like a mechanical problem. The uterus has fibroids within the muscle. It's very difficult for that uterus to stretch and accommodate a growing pregnancy. And the tendency is for it to want to contract and could increase the risk of preterm birth. There's also a small risk of placental abruption. Well, what is a placental abruption? That is when the placenta inside the cavity prematurely starts to separate from the lining of within the cavity. And that happens in rare instances where the placenta is overlying a fibroid. So the fibroid's taking the blood supply away, and that placenta can start to peel away. I've personally not encountered this in my time as an obstetrician, but certainly it is a possibility. And we really watch for this, especially in fibroids that are much larger. Very common, however, that these babies are upside down, are not presenting head down because the fibroids are sometimes obstructing their trajectory to make that turn and be head down. So it's not uncommon, even in situations where you're not recommended to have a C-section, that these patients actually do have to be delivered by C-section because the baby is malpresenting and most commonly in the breech position. And again, for similar reasons for the preterm birth, a lot of times these patients can have dysfunctional labor. You've been given the green light by Dr. Estes and Dr. Butts to have a vaginal birth. However, your contraction pattern is dysfunctional. We're not able to stimulate regular, strong contractions because those fibroids are taking up a lot of the myometrium, and it's just not functioning well. And so that does increase the risk of C-section. So C-section, you've heard it for multiple different reasons listed here, you would have an increased risk. And some literature actually says as high as a 6 times increased risk of being delivered by C-section if you have fibroids present, even without having had a fibroid surgery before. There's also a risk of postpartum hemorrhage. We have this awareness on labor and delivery. We know that if there are fibroids located in the muscle, that once the baby has delivered and once the placenta has delivered, it's sometimes challenging for the uterus to contract nicely because of those fibroids being in the muscle wall. And so we have lots of tips and tricks and preventative things that we do to try to help to get that uterus to contract nicely, but there is an overall risk of postpartum hemorrhage. What you're not likely to experience is an early pregnancy loss. It is very possible that you can have a miscarriage in the setting of fibroids that are located specifically inside the cavity. But overall, those instances are rare, and we tell patients that, once you've kind of gotten through the first trimester, we worry a lot less about that. There's less likely a chance that you have premature rupture of membranes outside of the risk of preterm labor. There's a documented very small risk that your baby could be at risk for growth problems, meaning growing too small because the blood supply to the placenta is somewhat compromised, but that is less likely to happen. And certainly would not expect there to be like a stillbirth or for you to have an increased risk of preeclampsia. So this is all good news. Considerations for patients that have had the fibroid treatment prior to having pregnancy. The big one is, how will we deliver this baby? And the route of delivery really depends on what it is that you had done and the extent of the procedure that you had done. We have to work very collaboratively with our colleagues that are performing the surgeries, making sure that we understand the extent of the procedure, whether it was hysteroscopic, didn't affect the myometrium at all, was it way out on the outside, not coming in contact with the cavity. All of these are reasons why we would have to be very considerate for your method of delivery. Most patients with fibroids and who have had fibroid surgery will actually have a successful vaginal birth. But we also consider C-section as a standard for anyone that has very large and obstructing fibroids. So in the instance where you are pregnant, you still have fibroids present, if they're located in the birth canal or close to where the baby has to physically come out, it would not be possible or recommended for you to have a vaginal birth. And so in those situations, we recommend a C-section. And again, if you've had complex myometrial surgery or you've had an extensive myomectomy and your surgeon has recommended that you have a C-section, those patients should be delivered by C-section and at an earlier time point than you typically would. So ACOG generally recommends a C-section somewhere between 36 and 38 weeks, depending on the extent of your surgery. And again, Dr. Williams mentioned that was really because of the risk of uterine rupture on all those points on the uterus that had been incised. You'd want to make sure that there was no risk that those scars could open up if you were to labor. And I believe that's it.
Okay, so I just want to take this opportunity to thank all of our panelists for their comments and all of the information that they've provided. We've been left ample opportunity to engage in some Q&A, and we're going to take questions both from the audience and from our participants who have submitted questions online. And so what we'll do is, while Dr. Estes is scouring our crowd to see if there are questions, and some of the questions that have been previously submitted have already been, I think, addressed. So I'm going to try to, do you have a question, Dr. Estes? No. Okay.
Thank you.
No problem. All right. So bear with me for a moment as I go into our Q&A and actually okay. One question submitted is what are the long-term impacts of repeated procedures like myomectomy and hysteroscopy on overall reproductive health? And how can women make truly informed decisions? How can we improve access to culturally competent care and support women, especially Black women, who disproportionately suffer from fibroids but often experience delayed or inadequate treatment? Since part of this has to do with surgery, I'm going to ask Dr. Williams to come back up to the podium and start to answer this, but I think this is open to the entire panel who wants to address any parts of this very thoughtful question. So Dr. Williams, you go ahead.
So that question covers a lot of topics, actually. In terms of when you have multiple surgeries, we always counsel patients with every surgery. There's risk of infection, bleeding, injury to surrounding organs and structures, and there's a lot of important organs and structures right next to your uterus. And with every procedure, especially like a myomectomy, we do encounter more scar tissue compared to other procedures, specifically because all of that scar tissue tends to be stuck to either your bowel or all of the other surrounding organs. In terms of multiple hysteroscopies, so whenever we go to resect anything inside the uterine lining specifically, that can cause basically a disruption. So there's a condition actually known as Asherman syndrome when there's a development of scar tissue within the uterine cavity. And basically that scar tissue will impact patients from being able to get pregnant and usually will also impact their period cycle. So usually they will be able to present and we can diagnose them based off of their symptoms. That is something that we are able to try to treat hysteroscopically by resecting that scar tissue. However, obviously, multiple procedures is not ideal. Whenever I counsel patients who might be a little bit uncertain about their future fertility, the typical rate of recurrence of fibroids after myomectomies, in about 5 years, it might be a 50% recurrence rate. But however, patients who actually get another fibroid surgery, that rate is more like 5%. 8 years down the line, that rate comes up to about 80%. And then usually about 15% of those patients will want to get another surgery at that time. Unfortunately, the only way for me to confidently say that I can get rid of your fibroids is by doing a hysterectomy. But at that point, you will have to be done with any future fertility desires. In terms of like cultural competency, like we mentioned already, about 70 to 80% of women will experience fibroids, and this number is definitely underappreciated within the medical community. Recently, we even did a survey on family medicine physicians in our own community in terms of can they recognize the symptoms of fibroids, and we're hoping to do more activities like this to better educate the general practitioners who probably will encounter patients who are experiencing these symptoms and may not know that this is probably due to fibroids. General education is very important to be able to hopefully capture these patients earlier rather than later, like we've already heard many stories before. I don't know if anyone else has anything else to add to that.
I guess I would just like to add, like any other medical condition that you experience, educate yourself on your actual presentation. So if you got imaging, ask your doctor to walk you through the results. What does this mean? We don't think that you're trying to be annoying. We want you to have a general understanding of your specific condition. Where are these fibroids located? Ask them the tough questions. How could this affect me? Do I have to do anything? Really try to understand your imaging. Should I get more imaging? What are the next steps? And really get a good, and you help to make yourself informed so that you feel comfortable with the decision that you're going to make. A patient today saw me for her fibroids that were the size of a blueberry, and without having an understanding of the significance of that size, wanted to have a conversation about surgery, and really having to take a few steps back. Let's understand what this actually means for you. How does this present for you? Are you having pain? Are you having heavy menstrual bleeding? Are you having the bulk symptoms, GI discomfort, bladder symptoms? And if the answer is no, then perhaps doing a major surgery. I'm a surgeon, I love to operate, but maybe that's not the right thing for you to have done. So really just taking a minute and not just, if it's a lot of patients coming at you all at once, perhaps taking an advocate with you, a family member, so that you guys together can piece together everything that's being discussed, but really trying to ask for your records, getting your patient portal, looking at your imaging, checking with your doctor so that they can better explain your results to you and how it impacts you, and not just what someone else has said or what has been shown on TikTok, or, I had to bring TikTok up at some point. But yeah.
I also just wanted to add that a lot of us have access to our moms and aunts, and they might not have known they had fibroids, and maybe their uterus was just taking out because that's what women did back then. But, if you have that conversation with your mom, if you're able to talk to her, even just symptoms, now that you're more aware of what those could feel or look like, you might find out that maybe your mom had, painful periods or heavy periods, and that gives you a clue into, I'm having some of these, so maybe this is not just in my head, or this is not just something that's odd. So I think family history is very important. If you have sisters, also asking them and talking about these symptoms that we have. And I think the second part also is that planning, if you have the opportunity to plan a pregnancy, and when I say plan a pregnancy means I want to get pregnant in the next 6 months, I'm going to go to my OBGYN and start talking about it and saying, hey, I don't think I have anything going on, but can we just like talk about what I need to do? Do I need to update my vaccines? My periods have kind of been heavy. Do I need to be worried about that? Or I haven't gotten periods in 3-4 months. A lot of people don't have that opportunity to plan a pregnancy, but if you know you're going to be getting pregnant soon and you're noticing that you have these abnormalities, I think that's a time to go into your doctor. It is not standard of care to do ultrasounds and everyone who walks through the door. As REIs, we always do ultrasounds, but by the time you're coming to us, you know, you've gone through a family practice doctor or a general practitioner, and they're not going to do an ultrasound unless you come with symptoms. And lastly, as you get older, fibroids will stop growing and they will eventually stop getting fed. And so that's menopause. So if you're lucky that you don't have heavy bleeding and you don't have all those other issues, they're not just going to keep growing for forever. At some point, they will stop, hopefully stop doing what they've been doing. So yeah.
Okay. Repeat it. So just repeating the question so that our participants on team. So Dr. Estes, just so I have it, the relationship between genetics and race and fibroids. And what was the second part of the question? I'm happy to start to answer that a little bit, and you may want to also address, and other members of the panel address this as well. I mean, I think this is an area of ongoing scientific inquiry and research. I think it goes without saying, but I'll say it anyway, which is that supporting this type of research with a condition that is so prevalent. Remember what we said, everybody, 70 to 80% lifetime prevalence that women will develop fibroids, which means the majority of women in this room, not to get too close for comfort, but you know what I mean? And so, you know, why something so prevalent, you know, why do we still have so much to study and learn? I think is an important question, and I think we need to continue to do the research where we can and investigate, you know, as much as we can. I don't know if anybody else wants to address. Dr. Dayo, come on up.
So while diving deep into nutrition, of course, genetics came up. So one of the things that is kind of thought to be potentially a link, but has not been tied well because we haven't studied it well enough, is that certain groups have certain foods that they eat that potentially might work with our genes that we have in those groups to make fibroids more prominent. So for example, there's groups that have looked at the fibroid tissue that we sent to pathology, and they've cut them open, and they've actually been able to find a few genes that they can say, if you have this gene and you have it multiple times, or you have multiple samples of fibroids, we're going to find it in every single one of these genes, in every single one of these samples of fibroid. What we've not been able to tell is, are these detrimental? Some of these genes have mutations from one fibroid to the other. And generally, humans are so diverse that our genetic makeup is actually more complex than we can begin to imagine. So they've not found just one gene that points to fibroids, they found multiple. And they're not able to come, so far, the data we have is there's no consensus on what is the actual cause of fibroids. We just know that if you look at certain samples, you're going to find certain genetic mutations. Ultimately, I think that when we look at population health, when we don't have the basic science to support it, then we kind of look at, if you look at Latino women and Black women and white women and Asian women, if you're seeing higher rates of fibroids in certain groups, then that kind of tells you if you have a mom and a daughter and sisters that all have it, there's something we don't know, but what we do know is they're all related. So there must be something that we just haven't figured out, which is why I kind of talk to the women in your life. We might not know the answer, but at least you're able to figure out if you are at risk for fibroids. If somebody else, your first degree relative has it, my mom had fibroids, all my sisters had fibroid, I had fibroids. So that gave me a clue knowing that my mom had surgery. And the moment one sister came up with, I'm having these symptoms, I was able to say, you should really get checked out because that's why mom had her uterus out. Talk to the women in your life. I think a lot of times women, we just don't talk about the issues that bother us, unfortunately. And if you talk to enough women in your life who are first degree relatives, chances are you will figure out some of these issues that we don't yet have the answers to.
So just to repeat the question for our team's audience, how do we think about age and how it impacts fibroid symptoms and management? Anybody want to start? Okay, Dr. Williams.
In terms of age ranges, I did mention before in terms of the recurrence when patients present, what are your chances of having to have another fibroid surgery further down the line? The biggest risk factor, as well as like having a lot of fibroids is also age. So if you present with less than 36 and you have a fibroid surgery, there's a pretty high chance that unfortunately you're not going to get to menopause where your fibroids quiet down. You're probably going to need another surgery at that point. So usually in that 20-ish to 30-ish range, we're at a point where we have to balance usually medical versus surgical management. And there's not really a point where we're going to obviously turn a patient away. We had a patient last week who was 15 years old that we did a laparoscopic surgery on, and she had a fibroid uterus. It can present in a variety of ways for a different variety of patients. I think it's just a matter of how can we make sure that we achieve a patient's goals with fertility, as well as their desires to keep their uterus if that is what they want to do, which that's another thing where we don't have a cutoff age for a hysterectomy ultimately for patients, especially if they're very symptomatic fibroids. So that's the way I think about it from a surgical standpoint, at least.
I think one of the themes that's been sort of repeated in this presentation has been there's no one size fits all approach to the management. And I really think that sort of age is an incredibly important factor to consider. Life goals, symptoms. I think there is research. I don't have the exact reference, but looking at sort of growth rates of fibroids according to race. So there's this sort of conventional wisdom that as women get older and approach menopause, that rates of fibroid growth slows down. That is the case for every race except for women of African descent. So we can't always necessarily, that certainly after menopause is a very, very different situation. And I don't say that to engage in fear mongering. I think we all as providers and as patients who are seeking care need to understand the natural history of this condition. And I think it's a call to action for us and our responsibility to say, there's still some surveillance that needs to happen. I still care about what your symptoms are, your bleeding patterns and your bulk symptoms across a lifespan, a life spectrum, and then just sort of continuing to individualize the care for patients. Is there another question in the audience, Dr. Estes? Okay, we'll take it.
Thinking about all the information, social media, TikTok, everything about fibroids in that realm, and of course, even for healthcare. How do you address that with patients who come in and may have some different idea about what they're coming in for, and then kind of getting together as a dyad towards their healthcare and kind of come out of a spot where you come to a conclusion that works best for the patient, given the information that they may have already had intake of social media?
So just to repeat that question, very thought-provoking, but the question is, how do we manage the expectations of our patients based on the influx of information they get from social media and other online sources, which may be valid and may not always be incredibly well informed? And how do we negotiate that? I'm going to tack on to whoever asked it in the audience, and thank you very much, because there's a related question in the sort of online submission, which is how do we then move towards reliable sources of data? What are the reliable sources of data that we recommend for patients, especially forums for women to engage in dialogue, conversations, database approaches? I'm actually going to ask Deshona to maybe give us her perspective on this, because I'm sure, we, took care of you and you were such an incredibly collaborative and thoughtful patient, but I can't imagine that you weren't hearing lots of signals and noise from other sources. You want to talk about that a little bit?
I think it's important to preface this with understanding that I work in marketing, and so social media is my job for a good portion of my day. That is what I do. And so I am inundated with it at all times. And of course, that was one of the first places that I went to when I was diagnosed with PCOS, when I found out about my fibroid, when I had to make decisions around whether or not I was going to surgically remove it, which I did because it had other implications for my own health and my own state of life at the time. And so I do think one of the things that was important for me was I had a team of doctors to go to with my questions. So yes, I would sometimes find some really weird things on TikTok, including to eat McDonald's French fries after my transfer. I did do it, so whether or not it worked, I don't know. I can't medically say that it did work, but I did have to make sure that I was balancing what I was hearing with then asking trusted sources about whether or not this stuff was actually factual or if it was just someone's anecdotal story that worked for them or maybe didn't work. It was something else entirely. And I think, in general, because of the fact that I have the knowledge that social media is really just what people are putting out there and it's what they want you to perceive in that moment, it's not really a trusted source for me. So that kind of played into how I made my decisions, but definitely Google was my friend. I was one of the people who didn't know what REI meant when I was first recommended to go see REI. So yeah, I think for me, and what I generally recommend to anyone who comes to me to talk about something like IVF, because I am pretty vocal about the fact that I went through it, is to really talk to your doctor and to make sure that your doctors are taking into account your holistic health. And it's not just your fertility, it's also the fact that that really affects your state of being. It affects your mental health, and your mental health has effects on your ability to actually carry your pregnancy. So there's a lot of things that I generally recommend, but the biggest one is to have a really good care team that you're working with and to never just take advice from TikTok. It's not a good source.
Anyone else want to tackle that question? Okay, thanks, Dr. Wright. Oh my, I know, it's okay.
I think it's a little bit of like the art of medicine. I recognize I'm not going to call you guys out. Some faces in here are future OB-GYNs, actually, students that will be obstetricians here in the very near future. So if there are any providers that are listening, I think it really comes down to that art of medicine and us fighting the urge to be paternalistic. We feel that we know the right thing for this patient. Don't have surgery. What do you, or have surgery? You just need to get these out. Do you really want to get pregnant? And fighting the urge to just kind of impart our views on what we think is the right thing to do for the patient. And sometimes they'll eventually arrive there over multiple visits. But reading the room and just kind of meeting the patient where they are, if things are not harmful, giving them the grace and the space to be able to decide with the right information what it is that they need to do for themselves. Again, but not expecting them to just be in agreement with you right away. They've gotten a lot of maybe sometimes misguided information or misinformation, but also there may be trust issues with the healthcare system, with you in particular, that you have to kind of work your way through earning their trust. And so, I've met a lot of antagonistic patients that have said, why are you wanting me to take hormones? Hormones can be sometimes controversial for patients. I'm like, well, I also don't want your hemoglobin to be 5, and I don't want you to go to the hospital and get a blood transfusion, but I need to understand their resistance, their hesitancy, what has it done to them, what have been the side effects that they've experienced, why have they arrived at such a definitive no to a specific medication, and just really offer them some grace and try to arrive at something that works for everybody.
Okay, I'm going to add one last thing to what's been said, which is that there are some multiple reliable online resources for supporting the kind of things and themes we've been talking about. Everybody on this panel, except for Deshona, because she's a marketing specialist and not a physician, that's okay, is a member of the American College of Obstetrics and Gynecology, right? This is the preeminent professional organization for OBGYNs in this country, and also a source of information for patients, right? I would much prefer that my patient tells me that I spent tons and tons of time on that website as opposed to some websites that are less trustworthy or social media sources of information. There are some foundations and organizations, 2 of which I'll call out here because they're outstanding. One of them is the CADE Foundation, which is an organization that supports the fertility goals of women broadly, founded by a physician who had infertility herself, and another organization, nonprofit called the Broken Brown Egg, which also sort of focuses on advocacy for women of color and again, women broadly who have infertility. Both of them have great websites, support patients who maybe even have financial challenges and barriers to fertility. And those are some great places to start. I should also mention the American Society for Reproductive Medicine, which is the parent American organization for fertility specialists. Go ahead, Dr. Estes. I think we've addressed this a little bit, but anybody want to take this on again? And I think maybe some of the things to also touch base on are sort of healing and recovery. There's a question that was submitted ahead of time to ask us about what are the kind of things that can be done to reduce the likelihood of fibroids recurring. Does anybody want to take that on? It's a great question. Yeah, go ahead, Dr. Estes. Come on. You've been roving Mike. Now you get to answer.
All right. Thanks, everybody. It really depends, I think, on what the goals are. So if the goals are pregnancy, then we head in one group. If the goal is not pregnancy, then we head another group. And also it depends on what the findings at the surgery were. And so typically we are thinking about medical management for patients who had fibroids, but taking a couple of months or a little bit of time to think and see how menstrual cycles are is a-okay. So I think the very individualized to each person. And so whether it's medication, monitoring, or attempting pregnancy, those pathways all are acceptable, and it is a shared decision-making process.
You want to things that patients can do or providers can do to reduce the likelihood of fibroids recurring, if anything?
Yeah, that's a good question and a tough question, Dr. Butts. So in terms of reducing our risk of fibroids, so, we have diet, exercise, healthy living type of things, but that really is not what's going to control the uterine fibroids from growing, because we're all going to get older. And as we have heard, that's the biggest risk factor. So I think that for me, the things that people can do are that you can have medical management with hormonal suppression. We can also do some of the medications Dr. Dayo talked about in terms of treating the symptoms of whatever those fibroids would be, but nothing in particular, I don't know if you're thinking of something, Dr. Butts, nothing in particular is going to prevent the fibroids, because those cells are probably already changing. So even though we may have taken out and operated on the biggest ones, probably those changes for the next fibroids are already there, and the length of time to get to a certain size fibroid is known. It's different in everybody. And so the approach has to be for that particular person and what we do.
Are there any other questions from the audience or any other comments that the panelists want to just as final thoughts before we wrap up? I'm going to actually give that one to Dr. Estes. Do you want to come up and just talk about leiomyosarcoma? Go ahead.
It's a really important question. It's a scary question because we talked about fibroids very casually. And so usually that's the way we think about them. They're 99% benign. As we get older, the chance of having a risk of a cancer within the fibroids increases. And so we counsel everyone about that risk. And so if you're undergoing a myomectomy, what can happen is, you're spreading some of those cells during the fibroid surgery, which can worsen your prognosis if cancer is identified. But the alternative is hysterectomy. So we have this big decision to make. So I think overall, we should be reassured that the chance of cancer or leiomyosarcoma in fibroids is pretty small. But as we get to 40 years of age and above, we think about it a little bit more, just so that people are informed of what the alternative in their decisions could be. Something else, Dr. Wright, that you were thinking about? Okay. So yes, good point, and something that we always think about in terms of uterine fibroids. So good to bring up.
So if there are no other questions, Jen, how are we doing in the chat? Any questions in the chat? Dr. Liu, Dr. Estes, can you take the mic back into the audience? All right. We have one final question from our embryology lab director here at Hershey Medical Center. Go ahead, Dr. Liu. No, it's not a silly question. I've always been trained, and I don't know if anybody else wants to comment on this, that it's a clonal cell. So it's one myocyte that sort of starts and divides. Fibroids are also consistent of connective tissue as well, but we think it's one cell that starts the process and divides and grows, as opposed to multiple different types of smooth muscle cells from the uterus. Dr. Estes, do you want to add anything more to that? So I just want to thank everybody who's attended this inaugural uterine fibroids and fertility seminar online and in person. We hope that you came away from this with a wealth of information. I want to take an opportunity to thank this outstanding panel of individuals for being very informative, very courageous and honest. We really appreciate it. And I want to close by saying this, which is, I think one of the things that everybody on this panel has pointed out, starting with Deshona, is that sort of offering outstanding health care to women who have fibroids and women generally requires a team approach and care collaboration. Hopefully, one of the things you've come away from this presentation learning is that this is a group of people who actually, we do work together. This is, not just, being on a panel and, new to us in terms of collaboration. I collaborated with Dr. Wright, Dr. Estes and I are partners. This is something that I think is incredibly important if we really want to not just talk the talk, but walk the walk of offering women with a very serious condition the best care possible that is transparent, that respects where they're coming from, that makes them feel heard, and that allows them to have excellent outcomes from pre-pregnancy to making decisions about medical versus surgical management of fibroids, to if they struggle to achieve a pregnancy, during pregnancy and postpartum. We've represented all of that skill set, I think, in an outstanding fashion here. And I just want to thank everybody again, and our outstanding team of members of our marketing team here at Penn State, the people who have pull this all together. I want to give a special thanks to our administrative coordinator, Jennifer Fiola, for making this a success. And hopefully she'll support us when we want to do it again next year. And hopefully this audience, and there will be still a desire to learn more about fibroids and the path that our patients walk very courageously through this condition. So thank you very much and have a good evening.